We're ready to go to the Montreal Heart Institute for a live case demonstration of a transcatheter aortic valve replacement. We have Jeannot Potvin and Reda Ibrahim with us. Do you hear us?
Yes, Nick.
Yeah, we do.
We can hear you very well. So welcome to Room PRD here at Montreal Heart. As you said, I have the privilege today to work with Jeannot Potvin from CHUM. Jean-François Dorval, also my colleague, is here to help. The echo is Dr. Basmadjan. You will see his nice image after. The anesthetist is Dr. Alain Deschamps. All the team working with us. I cannot name everybody, but it's definitely a teamwork what we are going to do. Let me show you the slide of this interesting case. So as aortic AV valve intervention, we decide to do here in this case a tricuspid valve in valve implantation. And the learning objective of this case is to discuss the option to replace a dysfunctional tricuspid valve. Should we go for another surgery or transcatheter procedure? Discuss the strategy and discuss the management after transcatheter tricuspid valve replacement. As I said, I'm working with Jeannot and Dr. Dorval for this case as operator. This is a 33 years old male. He's a trucker. He was referred by, he's followed at the congenital clinic first, but he was referred to us for tricuspid valve intervention. His initial disease was Epstein. He underwent bioprosthetic tricuspid valve replacement. It was in 2000. They put in place a 33 Medtronic mosaic valve that you will see very well. They did at the same time an ASD closure. So this valve is now 17 years old, so which is not too bad for a young patient like this. Clinically, he has exercise tolerance, no doubt about that. He has also shortness of breath, occasional palpitation. On physical exam, high central venous pressure, no leg edema. Recent testing, you will see his ECG, but he's still in sinus rhythm, no sign of AFib in this case. First AV block, also a right bundle branch block. Last stress test on him was in October 2016. No clinical sign or no electrical sign of ischemia, but lower than a predicted exercise capacity at 8.5 METs. The predicted value for him at his age is 12 METs, and it was also lower than 2012 because he did at the time 10 METs. The last author was benign with few extra beats. This is his initial ECG. So he has a right bundle branch block. You can debate it's potentially right ventricular hypertrophy also. But it's not a big concern for intervention on the right side. We're typically more concerned when patients have left bundle branch block and potentially with complete AV block while we play in the right ventricle. Last echo was performed in July. You will see that live, but the valve was, tricuspid valve was really degenerated. But he has also at least mild RV dysfunction and moderate dilation of his right ventricle. The left ventricle is perfectly fine. This is a CT scan that we did on him. You see epicardial leads. So pacemaker, it's not, at least endovenous pacemaker, it's not a concern in this case, but it can be a concern when you do intervention under tricuspid. But he has epicardial lead. And you see here two views of the tricuspid valve. We have a view en face and from the side. I don't know how much it's good. Nick, you can potentially comment on this, but the valve area was measured at 4.9 centimeters square on CT scan. So patient is under mild general anesthesia. He's intubated. We have TE guidance. We did the offline so far before the live procedure venous access under echo guidance. We did also a pre-close of the vein with a per-close. Patient is on heparin since the beginning of the procedure. We did a right hard cat. We will show you the data. And we have a stiff guide wire in place in the right pulmonary artery, ready to go. We already also put the Edwards E-sheet, an expandable sheet in the vein, 16 French, ready to go ahead for this procedure. Jeannot, do you want to comment on the characteristic of the valve in place?
So the valve,
Yes.
Reda, just before you go on, can you just tell us what was the contraindication for the surgery? Is it too old a patient? The guy is 33.
So there's no clear contraindication, Denis.
Was there like a right-sided, right heart stuck to the chest or anything that would preclude surgery? No?
No, I think it's a good surgical candidate. I think it's, but he's only 33. He has a big valve in place. We have the option to put a transcatheter valve here. I mean, I think you will certainly need another surgery at least once in his life. But we can certainly try to postpone that. If the new valve that we will put in place will not compromise another surgery. What's your thinking about that, Denis? Do you think that if we put another valve now in this tricuspid valve, it will be more complex for another surgery, or?
No, I don't. No, I don't think so. I don't think that it is compromising further heart surgery. But I think that, just for the sake of discussion, many of those young patients can be reoperated. We usually reoperate them from the right chest. And change the valve, and in his age group we can even bring up the discussion, should we put a mechanical valve even in the tricuspid position so he can have a definitive solution.
So I guess one thing about these valve-in-valve procedures is to postpone, as Reda said, and maybe avoid some anticoagulation if you were to consider a mechanical valve for some years. An active young male who's going to be biking and skiing potentially, and that may be an advantage of having another bioprosthetic valve put transcatheter, so that there's another amount of years that's saved without anticoagulation. What do you think about that?
Well, for the biking, how large are you planning to insert a valve if you want him to be very active? Because we're going to decrease the size of the valve, right?
I think, yeah, definitely.
Okay.
And just a comment. We have these discussions sometimes about these particular patients who are very young and have need a valve replacement. There's different algorithms you can follow in these type of patients. You can start with a transcatheter valve and then go to surgery, and then go to transcatheter valve and then go to surgery. You can do a transcatheter valve and then into a transcatheter valve. You can go a surgery. There's multiple algorithms. But
I agree.
If you give a transcatheter valve a value of 5 to 10 years value in terms of durability, and you want to reduce the number of surgeries in a patient's life, the best algorithm to do is to start transcatheter from the beginning and keep on doing transcatheter until you can't do surgery anymore. And if you just run the algorithms, the least amount of surgeries will be through a channel where you start with transcatheter and you keep on doing transcatheter until you cannot do surgery anymore, and then go on to surgery and then go back to transcatheter.
Yep. Okay, if you don't mind, let's go ahead because we want to show like nice thing live also. This is the, we can go back to the slide just 2 seconds, just to see the characteristic of the valve in place. Yep.
The mosaic valve that's in place at the moment is a 33 millimeter valve, and its height is actually 23 from the atrium to the ventricle. So with an internal diameter that would be around 30, the true ID based on the apps that we all know is 28. In these cases, a 29 sapien valve is actually recommended. Of course, there's a lot of, it's a very diseased valve. There's a lot of material within the annulus based on the leaflets that are very calcified. And as you can see, the gradient across this valve is significant, around 8 to 9 millimeters of mercury. So the plan here is to implant an S3 valve which you may know has got its stenting alloy with cobalt chromium. It's got a skirt, which is probably not absolutely necessary in a valve-in-valve position, because the intervalvular residual leakage is probably not an issue, but at least we do have the option of having a smaller size in terms of delivery system. There's the commander system that allows you to mechanically fine-tune the position of your valve, and there's also the flex that may be helpful here with the distal flex that is not present on the delivery system with the XT valve, which could also have been an option in this case, and this is what we're going to do in this patient.
All right, let's review now the echo. Dr. Basmajian will explain what he saw so far. Arsène, can you comment, please?
Good morning, everyone. Glad to be here. So we have the first images here. They're on screen, I hope, because I can't tell from here, but I'll presume they are.
Yeah, we see them.
You have left atrium, right atrium. Thank you. Here is the valve in question. Just to give you a point of reference, the aortic valve is right here. So here, this is absolutely not normal. You have a very calcified, thickened valve, very thickened leaflets, which are actually not really moving. Here's another view on 102. We're going to be working in these two views. Again, you see the valve, and there's the catheter that is, you'll see a little bit better going through the valve. There's a lot of spontaneous echo contrast. There's no evidence of a mobile thrombus or any really organized thrombus there, which is an important point here. This is a 3D view en face of the valve, a little bit angulated, mitral valve here, the aortic valve down here, and you can see the catheter going through. You see some components that are moving, but most of the valve is heavily calcified here. Here's a view, a ventricular view. Now we're looking from the apex of the right ventricle, or not really the apex, but the mid-ventricle, and going, here's the catheter, and this is what you can see that's moving. Nothing else seems to be moving. So this is a very calcified valve, giving you a more full eagle's eye view. There's actually, it's moving so little that I can't get a gradient. Obviously there is a gradient, but there's nothing going on here because the flow is so low, it's very hard to catch. Here's a few other images. We'll just move ahead. Here we're going to, Reda, they did a balloon of the valve. I don't know if you've mentioned or discussed that yet, Reda, but here we can see the balloon going up, the patient having a little bit of arrhythmia that was short-lived, and balloon going down. Another view again. Here you have the annulus. Here you have the balloon going up. Some nice images showing it deploying very well, and then going back down again. Right ventricle's here, the right atrium is here. And after balloon, well, we often see this. See a calcified valve, and we have a mobile component. So obviously the dilatation worked in the sense that now we do have some mobile components, but we actually have some flow. Two important elements here, which I didn't note at the beginning. The valve is leaking a little bit more than it was before, but what we checked at the beginning, obviously, to make sure there was no paravalvular leak, because having a paravalvular leak that would be significant would make the procedure moot for a valve-in-valve. So that was an important thing to note. So here we see a little bit more leakage, and now we actually have some flow. This is probably an underestimation of the gradient. The gradient pre was 8 on cath, but at least I have flow, which shows that we did actually change something by ballooning the valve. Little view, we have some mobile component here. And then to finish, well, we did this earlier, obviously, but I'm just showing the images now. I had a 28 by 28 inner diameter, and I had an area of 5.4 centimeters square. I think on CT you had mentioned 4.9, so it's not too far off. We're pretty close here, 0.40 millimeters square difference. And so just to show the post images, which we make sure of, there's no pericardial effusion, which is an important element, and no mobile components or any thrombus in the right atrium. And just to give you an idea, on the left side, everything looks pretty good. There's mild mitral regurgitation, the aortic valve's good, and the LV function is good, and no thrombus in the left atrial appendage in case we needed to do a cardioversion or anything for the patient. But right now, he's in sinus rhythm.
Okay.
All right, guys, let us show...
Reda,
yes,
sorry, just before we move on, any questions from the panel or any comments?
I was going to ask, obviously the area is a bit larger on the echo, but based on the, excuse me, based on the CT scan, an area of 4.9 would predict using a 26 valve, even though the known internal diameter in the valve-in-valve app would say we should use a 29. But obviously one of the issues is to minimize the amount of hardware inside and to try to minimize the post-operative valve-in-valve gradients, which we know are higher. So is there any consideration of using a 26 valve versus a 29?
Reda, you want to...
We definitely debate this at the beginning of the case. It's why we can show that what we did. Can you show Lauriane, please, Actually, Arsène said this is a wire in the right ventricle, the beginning of the case that you see to measure the gradient. But after we did not a valvuloplasty per se, but more a balloon sizing of the valve, because the valve is very, very calcified. It was a very tight stenosis. So we were not sure exactly. This is exactly what we debate. Should we put a 26 millimeter valve or a 29 millimeter valve? But I think we are, from the balloon sizing, we are confident that we can potentially push a 29 millimeter valve. Just to obtain maybe a larger area in this case. But yeah, balloon sizings were exactly to try to gauge which valve we should put.
So this is an ASD balloon, so it's not a non-compliant balloon that we would use for valvuloplasty. And the other thing, we know that with the material that's inside with the calcium, it's possible that we will not get full expansion of the 29 S3, which normally would be fully expanded 22.5 millimeters. The mosaic valve is 23, so it would fit in there, but it's likely that we may have a little bit of a larger or a height that's higher than the 22.5 when it's fully expanded. But at the end of the day, we had to make a decision, and we thought that the 29 would probably give us a great result. The 26 maybe would have worked as well, and we'll see how we go.
Yep.
Okay, we have just a comment from the audience.
Yep.
Yeah, hi. Jean-François Gobeil, Jeannot, Reda, nice case. I have a question with the pre-dilatation of that bioprosthesis. I thought it was kind of contraindicated. Yeah, go ahead.
Yeah,
because
so again,
we don't do that when we perform valve on the left side. Any comments on that?
So yeah, I guess the fear is to always tear the leaflet and end up with a severe regurg. But if it's the case on the right side, I guess there's a less consequence of that first point. And the second point, as mentioned by Jeannot, it was a compliant balloon that we use for AZ, and we typically don't tear the septum when we use very compliant balloon like this. So this is not a valvuloplasty balloon. This is more a sizing balloon.
But I think your message is important, Jean-François, in terms of trying to tackle mitral valves in this with a valve-in valve. If you tear apart the leaflets from the mitral by doing a valvuloplasty to start with, you may end up with pulmonary edema, which is not an issue on the right-hand side.
All right, let's go ahead with this valve. You can potentially show what we do. We will also do some fluoro image. So the valve is already loaded. An important issue with this kind of procedure, you need to load the valve appropriately on the balloon, because in this valve you load the valve with the skirt toward the right atrium, so like an apical procedure. You don't want to load this valve like a classical TAVI procedure, because the valve needs to be on the other way. So it was an important point to be sure of. And one thing with the S3 and the Edwards valve is that you need to bring the balloon inside the valve, what we call the valve alignment. So now the valve is inside. We are in the IVC. We have plenty of space to do that, I think. And Jeannot, we can show potentially what he's doing with his hand. Can we show the hands of Jeannot?
So basically, there is a locking system that allows you to manipulate the mechanical components. What we're going to do now is bring the inner catheter so that the balloon actually moves towards the valve. So it's the valve itself is being stuck on the pusher, which is what is required. And the balloon is being brought within the valve itself by having a left to right movement.
And you can notice that my right wire is in the right pulmonary artery. You see only the tip of my wire at 11 o'clock, let's say on fluoro image. We need to be sure that the wire is not moving, it stays in place while we are pulling on the valve like this.
So this is a potential concern when you actually mount the valve upside down. Of course, the balloon is being retracted against the leaflets. Normally, the leaflets are the opposite. Now, the tip of the leaflets are there, but this has been shown to be actually just a theoretical concern. And so far, the experience has shown that it's feasible to do so without damaging the leaflets when you bring the balloon back into the valve. So with a counterclock rotation on the other knob here, we can actually align the balloon within the valve itself, which is pretty good at the
I
moment.
think it's quite good, yep. So now the valve is on the balloon. Between the two markers, there's also a central marker, and it will push this valve towards the right atrium. We found a good view here to deploy this valve. It's RAO 10 and cranial 10. So the interesting thing with this mosaic valve is the fact that, see, the valve is very calcified, no doubt. There's also 3 posts, and there's also round dots on the tip of each post. So we need to potentially align the distal part of the valve with the tip of the post, meaning the marker. So I will push. There's 2 strategies with the wire. We can go in the right pulmonary artery or put the wire in the right ventricle. Typically, I like to go in the right pulmonary artery. You have more room with your wire after, and there's always the possibility to pull the wire to have like a different angle to attack the valve in place. So I will push this valve. As you maybe know, with the commander system here, there's always the possibility to flex the tip of the catheter. But if you flex, it's not like an aortic valve procedure. It will flex on the wrong side, and you will flex towards the lateral wall of the right atrium, which is not good. So if we flex, I'm not planning to flex at this point, but if we need to do that, we will need to rotate 100 degrees the delivery system to face the right ventricle. So let's try to cross, maybe Jeannot, slowly. Sure. We want to keep the position of the wire.
Give you a little bit of traction in there.
And if we are not going for any reason, we will flex after. So far, so good. It's going well. So we are already in place. I mean, it's almost too good to be true. We still have a pusher in place. We don't need to forget to remove that pusher. Arsène, you can potentially the valve in place. So Jeannot, yes.
While Jeannot is working on the device, can you comment on your rapid pacing strategy? Are you planning to do any rapid pacing during deployment?
Yeah, it's an excellent question. Typically, when we deploy aortic valve, we like to do rapid pacing. I mean, it's a must with the Edwards valve. We don't typically do that with the self-expanding valve. But in this case, because we are on the right side, and because there's a lot of calcification, we feel that it's not absolutely necessary. We were reassured also by the balloon sizing at the beginning of the procedure because the balloon did not move at all. But it's a challenge to put the pacemaker in place because typically we put the pace in the right ventricle, which is not a good idea when you're going to deploy a valve. But the option for pacing here is either a pacemaker in the left ventricle or in the coronary sinus. We were even discussing the possibility to give adenosine to stop the heart while we deploy the valve. It's another potential good option to deploy the valve.
It seems like, the balloon sizing was pretty stable, so I guess we're pretty confident to be able to have a stable deployment without rapid pacing here.
So, Jeannot, can you comment on what are the strategy maybe to align better this valve or with this system?
So, We had discussed previously the heights of both the bioprosthesis that's in place and the S3. So at this point, we have found a decent angle where we've got all of these three markers that are at the top of the posts of the bioprosthetic stenotic valve. And we were planning to put about 1 or 2 millimeters of the outflow of the S3 beyond those markers, so that when the valve actually shrinks, so with the deployment of the S3 valve, we know that the inflow of the valve is going to shorten on itself. So this shortening will happen from atrium, from the atrial side to the ventricular side, and the outflow, which is going to be 1 or 2 millimeters into the ventricle above those markers, is going to be very stable during the procedure, during the deployment. So this is what we're going to do, and because we know that we may not have a full expansion of the 29 valve because of the material, we felt that 1 to 2 millimeters above those markers would give us a good implant.
So at this point, the pusher is back. What you did just earlier, Jeannot, you see at the level of the 3 marker before the valve, the pusher is at that level. The valve can be potentially a bit more aligned, and we can be a bit more inside, I guess. We can play on the angle. I will go a bit more inside the ventricle and then pull after to be more in line.
It looked like when we were doing the valvuloplasty, the markers were a little bit more aligned on the bioprosthetic valve. Now it looks like one of them is a little bit off. Whether we can adjust that angulation, if you si on enlève un petit peu de droite, ouais.
It's still not too bad.
Not too bad. Come back on un petit peu plus de droite. Continue.
So Reda and Jeannot, it's Anita. Just a quick question. Yep. I noticed that the valve is not really coaxial, and we've done lots of these cases together. Can you comment on how the S3 behaves once you deploy it, and are you concerned about whether or not you're coaxial in the prosthesis?
But I guess typically when you deploy the S3, typically it will self-center by itself. So you need to touch on one side, and when it's touching on one side, typically it tends to center by itself and finish like quite well.
Whether that would change your implant depth is certainly something that you want to kind of predict when it's going to be more coaxial. We certainly have room here to play with the wire a little bit. Maybe some traction on the wire would bring the nose cone up, and we would be even more coaxial. But to start with, for me, this position is quite comfortable, knowing that it will kind of coaxial align itself very soon during the deployment.
Yeah, I think so. I think with this angle now, I think we will touch like soon the bottom part of the valve, and then we will self-center it and finish probably fine. There's always the option also to use the flex on your catheter. I have no flex, but it's possible to play with the flex. Yep.
Is there a reason why the guiding wire is pushed so far? Is it for stability or the guiding wire?
The wire in the right primary area?
Yeah.
It's for stability. Yeah, definitely for stability. Okay. And I like to push a wire very far. It's the tip of the wire tends to be entrapped in the distal pulmonary artery. You need to be careful. You can perforate, but it's a trade-off between stability and the risk of perforation.
Reda,
so
this is a super stiff?
It's a super stiff, yeah.
And how much floppy tip?
Super stiff.
How much floppy tip?
It's a ST 1 centimeter floppy tip. Okay. ST1.
You can see that if you were to leave the wire into the right ventricle at this stage with the nose cone and all that, you get a little bit less maneuver to play with the wire and find coaxiality. And it seems like having the wire going all the way up the pulmonary valve here might help us. I might give it a little bit of a try, Reda, if you want to.
Sure.
To pull a little bit on the wire, see whether that nose cone comes up, and if we get a little bit more coaxiality.
Seems to be good, huh?
Yeah.
And the other thing that you can do, you want to explain, Jeannot, what you can do with this microvalve?
So this catheter, this delivery catheter, allows you to do mechanical movement. So you don't have to play yourself with your hands to adjust the depth of the implant. With that that knob here, you're able to actually mechanically fine-tune your position. So at this point, whether we would feel it's a little bit too ventricular or too atrial, we would be able to just have the knob that's locked and then play with this knob to be able to bring the valve back or push it down to the ventricle.
See, now I'm playing with that. I'm going more ventricular, and I'm going on the other side. I'm going more towards the atrium now. See? It's micro movement without pulling on the catheter by itself. Are we happy with the position here, I guess?
Well, it looks
So
like
Reda and
not too
Jeannot,
bad.
The only thing you have to be careful when you do this, you need to look at your sheet because now you have to unsheet when you play with the little micro adjustment.
Yep.
You see
so
your
the pusher may come back in the way if that is your comment.
Exactly. Mm-hmm.
Yeah, exactly. No, that's a good point.
So at this point, the pusher is still within the third marker, so we haven't played a lot with it, but it's a very good point to make sure that you keep an eye on that.
All right. Can we go maybe on mag up? Can you mag up le champ de 20, s'il te plaît, Lauriane? I think we are ready soon to go.
On your side, Arsène, do you think the position's okay?
On echo, okay.
Yeah.
Echo seems to be fine also.
Reda,
Yep.
Jean-François, again, just before you open that valve, I find it moves a lot, personally. I mean, I'm not used to do that on the right side. Maybe it's less an issue, but I find it moves a lot. I know you don't have a wire to pace the left ventricle, but I don't know how what's your comment about
I guess it's moving. Yeah, I guess it's moving more since Jeannot pulled on the wire because now it's better. The alignment is better with the valve, but we have definitely more movement. But still, I will not say a lot. I think it's moving, but I guess it's still for me acceptable because it will touch soon to the tissue inside the valve. I think it's going to be fine. When it's moving a bit like that, you want to start to deploy probably a bit more ventricular because you have also always the option to pull on this valve if we are too low. But I guess Jeannot will inflate slowly, and we should be fine, I think.
So we'll do a little bit like an XT deployment where we will start with a slow inflation to start with, being able to adjust the depth of the implant when it's starting to be anchored, and then we'll go fully as compared to what we do on the aortic side where we basically start the slow inflation all the way through with the S3 as compared to the dark boning of the XT valve.
All right, so Jeannot, let's go ahead. Maybe we are going to do that with fluoro. I'm still happy with the position. Are you?
Yeah, it looks to me like it's
We
okay.
are a
It's
bit-
going to shorten from
yeah.
the atrial side.
We are definitely not aligned with the post. We are more ventricular, but I think I will try to pull on the valve while you're inflating. The pressure will go down, Alain. The ACT, we're good. We're trying to, the goal for ACT is around 250. We're above this. Okay, very good. So let's go ahead.
Do you want to record that?
Yeah, well, let's do that on fluoro, maybe.
Okay, yeah, sure.
We'll
All right.
keep that after.
So
Okay.
we start inflating. It's moving a
A
little
little
bit,
bit,
yeah.
pull. Yeah,
Good.
go. See what happened? The valve, yeah,
Okay.
inflate. So you saw that the valve dove in the ventricle. I was able to pull on the valve just to replace the valve where we want to be. And I think you did a perfect job by inflating this balloon, Jeannot. I think you have a nice position of this valve.
Yeah, it does look nice. It's probably 2 millimeters of the outflow being into the ventricle. It's nicely flowed out.
Yep.
We've got the skirt and the annulus of our
On va
new valve
récupérer le champ de 25, s'il vous plaît.
that is nicely aligned in the atrium, so we don't have too much prosthetic material sticking out into the atrium.
We need
So
to be
we'll-
careful. Oui. Non, on enlève le ballon, là. Okay, now.
There's a waste on that valve, of course, that was expected, and
Je sais pas si tu peux donner ton micro à Arsène.
we
Jeannot,
were
did you
kind
inflate
of
the valve
knowing
completely?
that.
So the valve is fully deployed with the balloon. And did you inflate completely, Jeannot?
I did inflate the syringe completely. So this was nominal volume within the balloon. And I did go all the way to the end of the inflation on the syringe. So we will kind of see what's happening now in terms of hemodynamics measurements. But the position, I think, is good. And we'll see whether that waste creates any restriction or residual stenosis. Arsène will help us out with that as well.
It's mostly because of the catheter. There's some TR.
If you have a wire Arsène in place, when we still have a wire in place, you can typically have like tricuspid regurg.
I agree.
We need to figure out what's the gradient, how much regurg we have, knowing that if we pull on this wire, we can have less regurg.
That's correct.
So Arsène, feel free to comment what you see on echo. We will definitely go back with the Langston pigtail to measure the gradient.
I'm pretty sure you pulled on the wire, as you said.
Yeah, pull on the wire, definitely.
People saw it on the screen.
Wire.
There was some very important centroprosthetic or intraprosthetic TR that is now gone. So
there's no more. There's no TR. There was a lot of TR before I pulled the wire.
Exactly.
We need to measure the gradient, decide if we're going to post dilate this valve. We don't like to do that too much, to be honest. Any comment from the panel?
Reda, it looks like a beautiful deployment. What's nice is that you have flaring of your prosthesis, which guarantees anchoring. So it's something that you'd like to see, and congratulations. It looks like a nice positioning, and we're looking forward to look at the hemodynamic results. Any comments from the panel?
Arsène maybe can comment. Arsène will comment the echo, and then if he's happy, I will go back. I will pull on my wire. So I don't want to pull on my wire. If he's not confirming on echo that it's fine. Arsène, what do you think so far?
I'm just going to actually. So far, it looks good. Since you pulled on the wire, there's no more leak.
Can you send us the echo images here in the room? Yep, thank you.
Oh.
Yeah, can you?
So this is a longitudinal view, and it actually looks good because you can. I don't know how it shows, but you have the catheter here going through the prosthesis, which is here. But what I like to see here is I see leaflet mobility. So I see some leaflets. I know you're going to have to trust me maybe because of how it projects on the big screen, but there's some leaflets moving normally there. And what's more importantly is I'll have to reset that, take off this, and turn it around. There. Okay. There we go. So actually, that looks good.
Yeah, quite round.
Here it's nice circular shape.
Yep.
You have the catheter here. You have leaflets moving in that view. So definitely on the 3D view.
I think it seems that we will probably not need to do a post dilation. Let me go with the pigtail to try to measure a gradient to compare with the beginning. We are in the right ventricle now. Let me pull on the wire.
So as you're doing that, Reda, is there any comments from the audience or from the panel?
I mean, it's a very nice case. We can clearly see what we call the neo-annulus of the bioprosthetic valve, which is the part of where the valve is at its smallest. So it guarantees anchoring of the THV. So it's a very, very nice positioning of the valve. Very good case, guys.
Thank you.
Thank you.
Let's measure now the gradient across the valve. I have what we call a Langston pigtail, so with two holes.
Reda, what was the RV function before?
So the RV function was bad, Nick. But the ventricle was dilated, but also was mildly. It was moderately dilated and mildly dysfunctional. So this is the. I think I will flush my line.
Just a question, Reda. I can't remember if this patient was already on Coumadin before, and what's your anticoagulation strategy for this patient now?
It's a very good question.
The patient was actually on Coumadin after the first operation for the bioprosthetic implant. We were planning to do a little bit what the surgeons possibly would do, and they can comment on that, but we were planning to put him on Coumadin for at least 3 months. Whether we need to go further than that is a little bit unclear. One thing that I wanted to know was how much of new material was going to stick into the right atrium to orient the decision. At this point, there's not much more than what was in the past. So I think 3 months of anticoagulation will be indicated and sufficient. Any comments from the surgeons?
We typically would do at least 3 to 6 months of anticoagulation on any bioprosthetic valve. I think that would be their kind of a general approach to this. I would consider doing this longer than if he's tolerating well the Coumadin. I guess the goal is to make him feel better and to reduce the burden of this valve being in. I mean, there's really no data what this valve will do eventually. So I would consider having this for a longer period of time, because it's going to be at risk of thrombus formation for sure.
But you would consider that there's more material than for a regular
Absolutely.
the prosthesis. You know, you got
Absolutely.
a valve in the grid, partly into the RV. Anybody or the cardiologist has other opinions? How long should they be treated?
I mean, when you look at the experience from TAVR in TAVR or TAVR in valve, I mean, this is highly risk of thrombosis. You're a low flow state. I mean, I will consider lifelong. I mean, I to be quite honest. And there's still quite a gradient there. So I'm kind of concerned. So I will, for sure, 1 year reevaluate. I mean...
Est-ce qu'on peut mesurer le gradient?
So Reda, can you tell us what you're expecting as a successful result on the hemodynamics in terms of TS and TR?
So typically, TR, we really want to have no TR. It's
Trace.
minimal here. It's trace. So we expect no TR. This is the case. In terms of gradient, we expect a gradient, but how much gradient, it's difficult. We want at least to reduce the gradient by half, if it's possible. It's the case at least on the echo side. On us, it's 5 millimeter of mercury. So it was 9 at the beginning. So almost half, but you need to remember that after replacement of the valve was so stenotic that you increase the cardiac output. So after the implantation of the new valve, now you have a better cardiac output that we'll re-measure, and it contributes also to the fact that the gradient is not going to decrease like completely. This is the thing that we never want to forget. So in this case, I will probably accept this gradient, although we can debate should we push on this valve. I would probably not do that right now, because there's always a risk to damage the leaflet by doing this.
One thing that's
So what's the mean
interesting about the
gradient, Reda,
gradients...
at the moment?
I mean, it's 5 now, 5.
What I was going to say, Nico, is that one thing that's interesting about the measurements and the severity criteria, when you look at standard echo criteria, of course, you'd like to have a gradient that's below 5. However, when if you look at the VIVID registry with these sub-analysis of all the valve-in-valve for the tricuspid bioprosthesis, they kind of discovered or realized that a mean gradient of 10 or a mean gradient that was higher than 5 was so common that they actually used 10 as the gradient that was the severity in terms of within this registry. So I guess here, if we're at 5, we're pretty much at the cutoff where we would be pretty happy, and I think we can expect functional improvement and symptomatic improvement in this patient for sure.
I have a question for the surgeons. Maybe Dr. Bouchard, you talked about that before, talking about biking and everything. What would be your expectation after surgery for the gradient like that?
If that would be a surgical replacement? Well, you know, if you have a large valve and you take out a size 33 bioprosthesis and you replace it with something of the same size, no, we should be aiming to be, you know, in the 2.5 range, something like that. I don't know if the other surgeons, but But that's a bit troublesome. Dr. Potvin was talking about we might put the mark for success at 10 millimeter of gradient. Through a tricuspid valve at 33, 10 would not be acceptable for that patient for sure. 5 is...
No, of course not. Of course not. Not 10 millimeters. I was talking about what the cutoff was for severity of stenosis in that registry, which was at 10. So we're certainly not aiming having a gradient that's close to 10, which would be close to severe. So certainly less than 5. And whether we should be able to get more than that would be perfect, but in this case we've got more material, but you can keep going.
And I think interestingly enough, Arsene can comment, but on the echo side he's measuring, I think Arsene 2 millimeter mercury.
Yeah, I had 4 to begin with and I have 2, so it is...
So you see on echo side he's measuring 2 for any reason.
And what were the gradients right after the surgery in 2000?
Oh, good question, yeah.
I mean, the comments are good. I think that from a surgical perspective, we really put a 29 in a 33-year-old man, and so just for the sake of conversation, it's likely that if you put this gentleman to bike or to whatever he does, a 33-year-old, that gradient will be higher.
Yeah, I agree. He's a trucker. He's very active. He's very against Coumadin, to be honest. But I mean, I think 29. We'll see. I mean, I think he's going to be fine for a few years, certainly. But we will see. Can you comment?
Just to play the devil advocate, if you put any surgical valve on a treadmill and stress echo, you're going to see increasing gradient also. Absolutely. So I think that's very interesting to see when you talk about mechanical and the gradient increasing during exercise versus biological and versus transcatheter. I think that's a field that needs to be explored because life occurs in exercise and not at rest. So.
Very good point. Very good point. Arsene, can you comment on the where's the valve is in the right atrium? Is it? Do you see this valve?
Actually, we do. It's
in the right atrium because I mean this is something that we want to be sure. We don't want too much valve in the right atrium because it will put this patient more at risk of thrombosis. But it seems to be quite nicely.
It's actually not atrial. It's more on the what we'd call like ventricular.
Not atrial.
Let's remember
just
this patient's
fine
basic
with the
anatomy
analyst.
and Epstein, if I'm not mistaken. So, what's the atrium and what's the ventricle? But Killer, the atrial level, what we would call the neoatrial level, is here, and your valve is right there. You could see on this view, it's a thin leaflet. So its mobility looks. The 2 leaflets I can see have a normal mobility. So it's I think it's a very good position.
I'm happy with the position with this valve. To be honest, we said to this patient, we are definitely going to anticoagulate him for at least 3 months to try to prevent any thrombosis. But after, I think I will be definitely confident to stop the anticoagulation. We don't have too much stent in the right atrium, and it's quite good.
So, Reda, what is your plans to follow up with this patient now? You're going to give him Coumadin for 3 months. You have a valve here that is potentially oversized. As we see here, we have a waist on the valve, so you might have some pinwheeling of your leaflets. We talked about the risk of thrombosis in a low flow state. And we do know that echocardiography sometimes misses, subclinical leaflet thrombosis. So what is your strategy here in trying to follow up this patient on whether or not to continue the Coumadin at 3 months? So if he's...
I was planning to see him at the clinic with a stress echo. But I'm happy to know what you can potentially suggest. Do you think that we should consider a CT scan on him? Any advantage of this? Of course, he's 33 years old. We want to minimize radiation exposure. There's a limit of scan that you want to do in a life of someone like this patient. But I think a stress echo will be fine.
So let's ask the panel. Anyone on the panel have any ideas on how to follow up this patient with respect to, of course, we're going to do some clinical and some echo. Would anyone do a CT scan at any time point?
I'd only do it if I think for the reasons that have been stated, I would feel most comfortable if he was on lifelong Coumadin, especially left with this gradient. But if he did not want that, then if the gradients increased for any reason, then I would do a 4D CT to see if at that point we could convince him to go on Coumadin if there was some evidence of leaflet thrombosis. But I wouldn't do it routinely.
Okay, well, excellent. Reda and Jeannot, congratulations. It was a very, very nice case. Now, I'm almost sold for the valve-in-a-valve tricuspid valve replacement, you know. Just need to think of it during lunch. And we're going to move now to...
I guess using a minimal approach, no?
But I think we should give them a round of applause.
Yes.
Thank you.
Just
Thank you to the team.
maybe let me just thank very much Jeannot Potvin from the CHUM, who actually performed super well in an environment that's not necessarily his. So thank you so much, Jeannot, for doing this as a great collaboration. Thank you.
Thanks for your invitation. I truly appreciate